All right. Well, good evening, everyone, and welcome to Innovations in Community Care, our 10-week series of brief talks on important topics in community medicine. My name is Dr. Lawrence LeBeau. I'm the Program Director for the Wright Center for Graduate Medical Education National Family Medicine Residency Program that organized this event. The speakers you hear from each week are faculty members from one of our training sites. If you've been with us before, you know I always say one of our training sites because our program is the only national consortium of teaching health centers that have come together to form one ACGME accredited family medicine residency program with osteopathic recognition that operates as a single program with training locations in 4 different states. The community health center partners are El Rio Health in Tucson, Arizona, HealthSource of Ohio in Hillsboro, Ohio, HealthPoint in Auburn, Washington, and Unity Healthcare in Washington, D.C. If you're a student considering applying for a family medicine residency, we'd love to meet with you afterwards and answer any questions that you have. We have some faculty, and by the time we're finished, we might even have some residents, if we're lucky, from our program who will be available to talk to you afterwards. By recognizing that everyone's time is valuable, we want to keep each talk in this series both high value as well as brief and to the point. And so the presentation tonight should last about 20 minutes or so, followed by plenty of time for questions and answers. And with that brief introduction, I'm going to hand things over to Dr. Nathan Kittle and Dr. Cara Dalbey from our HealthPoint Community Health Center partner site in Auburn, Washington, for their presentation this evening on low barrier care model for people with substance use disorders. Drs. Kittle and Dalbey, take it away.
Well, thanks, Dr. LeBeau. So I'll go ahead and get things started. I'm Nate Kittle. I'm a faculty member from our Auburn, Washington site at HealthPoint, and I have board certification in family medicine, but also addiction medicine. And then Dr. Dalbey is our behavioral sciences, behavioral health faculty member at the same location. And so we are going to be talking about low barrier care model that we've developed over the last, I think, 3 years or so now for kind of meeting people where they are with their substance use disorders. And so goals of today's presentation are just to understand addiction as a chronic disease, understand why we provide a low barrier treatment for people, learn how to care for patients and about a patient's experience and the power of language, how to deal with difficult patients with substance use, or maybe care for sick and sometimes complicated patients with substance use disorders. Learn more about our integrated behavioral health services and the role in treatment that our integrated care has. So just what is substance use disorder? Substance use disorder is defined as a primary chronic disease of the brain affecting reward, motivation, memory, and related circuitry. And really what this gets at is that, it's a chronic, meaning it's going to kind of come and go throughout time, just like any other chronic diseases that we treat are. It's, a 4-week inpatient stay isn't going to cure someone. And so it's something that a patient or someone's going to have to deal with over time. And we need to understand that as clinicians caring for them. And it's really going to have this kind of diagnostic criteria that, it's this loss of impulse, it's this recurrent impaired control over the use of the substance. And it really leads to a dysfunction in various aspects of the individual's life. And so some of these structural changes that take place in substance use disorders or opioid use disorders that list here on the screen really impact the reward system in the brain. And really what this does is that it decreases the regulation and kind of that control that people have. And so it makes it kind of impairs memory, it impairs planning, it impairs kind of responses to triggers that people may have. And so if you're without the substance, you're going to be more irritable. You're going to be unable to handle kind of typical stressors that you would be able to have with the substance in your brain. And so in the addiction world, we kind of think that it takes generally about 2 years of stability or abstinence to really rewire the brain. And so it's this, we don't expect abstinence to result in someone returning to normal in a month or in 2 weeks. It really can take a long time. And so it's just really important that we understand that, especially as primary care physicians working with people over time, that if we can get to that abstinence piece with people, that it may still take a few years until they're really able to adapt to life and adjust to life in a way they could before they began using substances. And so it's really this notion that addiction and substance use disorders are really chronic diseases, just like any other chronic disease that we have. And there's this structural component to the brain. There's a structural component that takes place that impairs a person's ability to kind of respond to their environment in ways that we typically would expect. And so really meeting people where they're at, this low barrier care model, it's really just this idea of this range of treatment goals. And so on one side, you have sustained recovery and abstinence from all substances. And on the other side, you have harm reduction and minimizing the harms from ongoing substance use. And really, in a lower barrier approach that we've been able to develop, it's acknowledging that people aren't going to become abstinent in a week. People aren't going to become abstinent in a couple of days, maybe even a couple of years. And so what can we do to create a system that is adaptable to the patients we're seeing? And so what that might look like is, a lot of addiction care, especially when I was going through training, 6 or 7 years ago now, it was really structured. It was really, you have to go through these 12 steps. You have to go through this inpatient program. You have to go through this. If you don't do that, we're going to kick you out. We're going to, let you go off to the side and kind of just not be a part of our care team. And what we realized through some, scientific research, through just trying to understand addiction more and bringing it more to the forefront, is that doesn't work for most people. Most people are going to lapse. Most people are still going to use. I'm working with some patients that are still using 2 or 3 years later after I started working with them. And so it's, how do I minimize those harms? How do I meet them where they're at? And then try to move them along this continuum. I think my ultimate goal is really safety and having them be as healthy as they possibly can. And usually that's with no substances in their system. And so how can we move people along this continuum? And that takes, years. It doesn't necessarily happen overnight. And for some people it does. But it doesn't always do that. And that's really the reason why we created this lower barrier opportunities for patients. And so what that looks like at our training sites is that we, 3 years ago, we created 4 hours where anyone can walk in and you get care for the substance use disorders, mainly opioid, and it's kind of used as a buprenorphine Suboxone clinic, but people have come in for other substances as well. And so it's really just this day of the week where people can come as they are in whatever state they're in and get cared for. And so I think that's just the important piece. They don't have to show up at Tuesday at 3 p.m. For their 3:15 appointments, and if they show up at 3:25, we aren't going to see them because because they were past the time. And that just doesn't work in substance use disorder. That doesn't work when your brain chemistry has been changed, as I talked about earlier. And so really meeting people where they are along this whole continuum is the important piece of how do you adjust our systems to meet people rather than having people conform and meet our systems, just because it's really not possible when you're really just trying to survive and feel well to overcome some of those changes that have happened in your brain. And so why do we have this low barrier approach? Substance use disorder is a chronic disease, just like hypertension, diabetes. So would you turn away someone with uncontrolled diabetes who still eats chips and cake and comes in routinely with high blood sugar? Of course not, And so, I think another reason why we've had to adjust our care is because of the opioid epidemic. When we're having, in King County, that's where our site is located. In 2019, we had 308 people die of overdose deaths. That's 3 times the number from the year previous. And so I think it's a growing epidemic. I recently saw a stat that in our county in July, there are more people who died of fentanyl overdoses than there was of COVID-19. And so unfortunately that's reversed with this Delta variant, but just showing that, COVID's still happening, opioid overdoses are happening at a higher rate than ever before. And so medications like Suboxone and creating treatment and this relationship with an integrated care team can really make the difference for people, and really just engaging in care is really what's important. So So how do we care for patients? What are kind of the philosophies that we adhere to? And so for us, low barrier care means that medication's available and care and treatment is available quickly and as easily as possible. And so we're going to give people their Suboxone on the first day. We have walk-in hours, as I already discussed. If people miss a visit, we're going to actually reach out to them and try to get them to come to the next walk-in clinic, or try to get them to be seen at a different day if it's convenient for them. If we do discharge people from care, I think I've only done that probably 2 or 3 times in the last 5 years. That's really with a plan or criteria for resuming care. And really the only reason we've kicked people out has been because they've been not taking their medicine. And so other than that, I think we've been able to deal with most people as I'm kind of going through my head rapidly. And so just been, a really great thing for our clinic. And so I think this last piece is really important too. And that it's really just being nice to people is really what low barrier care is, and meeting them where they're at, as I keep saying. And it's based on the principles of kind of harm reduction, which is a belief in meeting patients where they're at. It means centering our care around the basic dignity and rights of humans and just who they are, and people who are using drugs. As the other slide said, nice people use drugs. And so it's not labeling people with the stigma that can exist. And so, asking people what their health goals are and centering their goals and their care around those goals. And it may not be abstinence in a month, it may be abstinence in 6 months. And so how can we work with them through that? Continuing to care for patients who are intermittently using and kind of returning to use and having those lapses. And then I think this last bullet point is really important, especially with, IV use can lead to higher overdose risks. It can lead to hepatitis C and HIV spread. And so how can we talk about safer practices with our patients and being okay with saying, you're currently using in your vein, like if you thought about smoking your heroin, or if you thought about other ways to use that might be safer. And so that's really what we try to bring to our clinical experience and our care for our patients. And then, I'm not going to go through all these, but language really, really matters. And patients are going to keep coming back to you if they like you. If you're kind to them, if you respect them as a human. And really that's the goal of this care model, is to not, belittle the person, not belittle the experience, and really just seeing the person as the person they are, and then working with them on their chronic disease and their chronic illness, just like I would with my patients with diabetes or hypertension or obesity or whatever else it may be. And so, really trying to change our language as much as we can, to, instead of having it be this kind of negative connotation that's associated with some things like addict or junkie or alcoholic, and really trying to be the person first language and talking about positive, negative drug screens, not clean or dirty, and things like that. And so, there's a whole list of words, and there's a document, I think it's actually from either early 2000s or late 90s, about changing the language of addiction, put out by the CDC. And it goes through a lot of these things, and, and it's still taking, 10, 15, 20 years for our medical community to catch up to that. And so, it's really about how can we distress this experience? How do we meet people where they are? And that's how we're able to meet, kind of lower our barriers on our clinic. And so it's, we need to be nice, we need to be patient, we need to be supportive. And so it's really hard to do this work alone, which is why I'm so grateful that Dr. Dalbey's in the clinic that I'm in, and we have some other team members as well that help out. But it's really great to have a team, because this is not how we are taught. This is not how our society teaches us. This is not how our medical community teaches us to work with patients who have substance use disorders. And so it's really easy to be like, these patients are lying and wasting our time. But it's actually important to flip that as much as we can, and just respond to the patients. And, they're trying their best, they want to do better. And so how can we do the best we can to check each other? And that's where this kind of integrated care model helps me as a provider. And it also really greatly helps our clinic. And so I'm going to pass it over to Dr. Dalbey to kind of talk about that care model and how we use that care model for our substance use disorder patients.
Perfect. Thank you, Dr. Kittle. Okay, and I'll just tell you when to switch slides. Yeah, so good to be here. My name is Dr. Cara Dalbey. I'm a clinical health psychologist and the behavioral science faculty here at our residency. I'm just going to talk a bit about kind of a broader overview of our behavioral health model here at HealthPoint among all of our clinics, and then kind of specifically how that then relates to our substance use disorder clinic and care. So HealthPoint, we have embedded a model since, gosh, the early 2000s, which is called the Primary Care Behavioral Health Model, or PCBH. This is kind of the technical definition around it, but really what it is it's a population health model, not a mental health model. So the idea is that there's typically a health psychologist in a setting, and it's fully integrated care. It's not, co-located where, maybe the psychologist or the behavioral health consultant is around, but there's separate systems, separate EHRs, separate scheduling, where it's really fully integrated into the day. And really the purpose for our role is to be integrated into care, not only for improved patient outcomes, but to really basically help providers and the patient care aspect to really kind of focus on, chronic disease, whether it might be small versus big behavioral changes. We meet with people on a more brief basis, so we can kind of do more of a kind of a broad approach to who we meet versus a really specialized traditional model where we only meet with a few people over time. And so it's fully integrated into the primary care clinic. And then again, the aspect with our substance use disorder treatment, so we try to do a lot of kind of teaching of certain strategies of how to work with patients around substance use disorders. So we're thankful to have this model. And it's, like Dr. Kittle talked about, substance use disorder, it's a chronic condition, just like we help provide diabetes management or hypertension management or weight management, and really approaching it that way to work collaboratively with the providers and the other team members to hopefully improve quality of life for our patients. Okay, next slide, please. So really the brunt of the PCBH model, and similar to our kind of our low barrier walk-in clinic model for our substance use disorder care, is really the idea of having it be an available care team that collaborates, and that it's same day, right? It's same day access, that if someone's walking into our, the designated time on an afternoon, we have walk-in low barrier care, that not only do they meet with the provider, but they have hopefully the availability to meet also with one of our behavioral health staff members. We also have, I'll talk more, we have a chemical dependency specialist on site. So same day access to a variety of team members. COVID obviously put a dent in that a bit, but we really strive to have that be same day access for a variety of disciplines. And we do practice a lot of what are called warm handoffs, where if patient is coming in, seeing provider, and then whether it be for substance use issues or something different, we're available to come in, see the patient in the exam room, collaborate with the provider, and kind of round out the treatment plan. And again, it's not a traditional mental health model. We don't call it therapy or counseling. It's really the idea of kind of more like health consultations. Visits are brief. Sometimes we meet with people for maybe 5-10 minutes to talk about a behavioral approach or intervention, or get more history. Sometimes it might be upwards of 20 or 30 minutes. And some folks we meet once to maybe do some health education or talk about a behavioral goal or just some support. Some people it might be a handful of times. And I think, kind of with the substance use disorder treatment, around the idea too of that continuum of people, it takes time to change. It's not this linear progress through time towards full abstinence for everyone, for most in fact. And it's really this idea of meeting people where they are, and for patients, especially with substance use disorders, of really targeting to their stage of change, how we can support where they are and what their goals are. And again, our role is to be there to provide really prompt and same day immediate access to the provider after the visit. And we'll talk about this more on another slide, but really, again, the goal of this type of behavioral health program is really improved patient outcomes for functioning and overall health. It's not necessarily making really big changes in lots of people. It's helping make small changes that people can sustain over time. And it really does kind of focus on a lot of health education. And I would say, not only in addition to the support for the substance use disorder treatment, we do a lot of health education, a lot of psychoeducation around whether it be co-occurring disorders that people are having, how they're coping or managing in their process through recovery, and just really trying to kind of really help improve people's health literacy as well. Okay, next slide, please. And so on site for us, our care team, and this is somewhat typical for most clinics, although we're very proud that we are the only clinic that does have a chemical dependency specialist on site. So obviously we have our medical providers, our residents, and our faculty, and then have myself. And then we do have a chemical dependency specialist on site. So he is here full time, and that is fully what his position is and what he supports. So he helps a great deal, not just with our walk-in clinic days, but patient follow-up. He's the one who's also been helpful in starting a group that we've done for patients as well. So that's been a huge support to this program as well, and our clinic. And then we also have, we have a pre-internship and then a postdoc residency program for behavioral health and for psych as well in HealthPoint. And so on site here at Auburn North, we do have a postdoc resident as well. And then we do it typically at least 1 day a week, but others as well. We have a float providers. So again, whomever is on site the day that patients are coming in for their follow-ups or for their walk-in, we try to do as many handoffs as possible when it's appropriate and patients are interested. And we try to help kind of just really round out their care team that way with all of these different providers in addition to their medical provider. Okay, next please. And so, yeah, so in relation to, substance use disorder treatment, we know that integrated care makes a difference. And basically the definition of it is that it's an evidence-based approach for people with substance use disorders and often with co-occurring psychiatric disorders because those typically are co-occurring. And the idea is to really, for patients who either have co-occurring or if it's really primarily just substance use disorder, that they have that access to the full team, the full care team. And again, can't stress enough that it's, same team, same location, same day. People don't have to come back for separate appointments or go to a different physical location or have a different scheduling system. It's all accessible in one location. Okay, next, please. And so, really to echo Dr. Kittle as well, principles of integrated treatment don't differ a lot from, really where substance use disorder treatment has thankfully gone over time towards being much more low barrier and focusing on harm reduction. And again, we really, and especially with our residents, try to focus on how to train recognizing stages of change that people are in, because not everyone comes in necessarily full action stage. Some people are still contemplative about their recovery or sobriety, and people go back and forth. Again, it's not a linear progression. So we really try to match that for people. And typically in terms of kind of teaching and training, what we focus most on in terms of technique and intervention are cognitive behavioral approaches and a lot of motivational interviewing. So really trying to train our residents in that as well. And that, again, multiple formats, right? We have the walk-in, we have individual visits, we also have the group visits that we offer. Always encourage family or kind of support people to come to visits as well, because that's a huge aspect of recovery, one of the biggest, if not the biggest. And then again, just really having, if they are doing medication-assisted treatment, that they're having that integration with the psychosocial services, with our behavioral health and or our chemical dependency specialist as well. Okay, next slide, please. And again, it's the recovery model around the treatment goals are patient driven. It's not just that we expect abstinence from everyone or that they do have that linear progression in recovery, and that we really do, I think, really do a great job of fostering a culture and an environment that has unconditional respect for patients and compassion, where it's non-judgmental. And that's feedback we often get from patients, and that's the best compliment we can get. And again, that the care team is there to hopefully engage patients, support their recovery. And the big thing too around this is on the patient's goals and functioning. We really try to, especially with our residents, trained to ask that of what's the patient's goal? It might not necessarily be abstinence or, reduction in one substance versus maybe not another one. And really what are their goals and how do we support that? And so through that, practicing a lot of shared decision making, and again, that involvement from support, that's just huge. So we try to do that as much as we can. Okay, next one. And so again, just kind of in summary, that really we know that integrated treatment for substance use disorders and really any chronic disease is so helpful, and it is effective, and that we really try to support the recovery process, whatever that might look like at whatever stage it's in, and that we have that wonderful kind of multidisciplinary team approach that's, again, very accessible for support, and that we really, as a team, try to have a consistent message about support and health promotion or whatever it might be to really support the patient through whatever stage they're in. So that's it.
Thank
Any
you.
questions
all.
for Dr. Dalbey or Dr. Kittle?
Yeah, questions.
If there are no questions tonight, I want to remind everyone that all of our sessions are recorded and available for viewing afterwards on the Wright Center for Community Health YouTube channel. I put a link to that YouTube channel site in the chat box. I'm also putting a link in the chat box for anyone that's interested in learning more about the residency and fellowship programs offered by the Wright Center. So one last call. Any questions for our speakers tonight?
Clearly covered all of it, so there's just no questions. It was that amazing.
Well, thank you everyone for joining us tonight. Hope you're able to join us next week for the 7th in our series when Dr. Elenia Donovan and Dr. Khalid Ibrahim will present on medicine for the incarcerated. Till then, enjoy everyone.
Thank you, everybody.